when we take a look at the National HIV/AIDS strategy, which I think most of you probably are familiar with, we have the 3 goals that are related to reducing the number of people who become infected, increasing the number of folks who are in care, who have access to care, and optimizing health outcomes, as well as reducing HIV-related health disparities. The 4th goal, which is not always cited, is for us to achieve a more coordinated response across the national response to the epidemic, especially across the federal government. The facets of the strategy was, and because I have the opportunity to, I'd like to acknowledge one of my predecessors, Jeff Crowley, is in the room, and Jeff helped oversee and really authored and oversaw the implementation of the National HIV strategy, so hi Jeff. And it was very intentional to have a limited number of action steps that very thoughtful in that we can't do everything, so we need to be very specific, have some quantitative targets to meet. We had 5-year targets, and emphasis on evidence-based approaches, and bringing together most of the folks, most of the agencies across the federal government. There are some that were not initially included, and I've had a wonderful opportunity to have conversations with both the Department of Transportation and the Department of Education, and very excited about exploring ways in which we can bring them in and have them be involved. When you think about new infections in the U.S., and I'm going to move through these because I believe Dr. Fauci covered those for you, an estimated 50,000 new infections, unlike in our countries that Dr. Burks talked about, the greatest new infections are among MSM in this country, with a 48% increase among young Black MSM. Prevalence among MSM 40 times greater than other men. When we think about women, Black women are most impacted among all women. Latinos are disproportionately impacted, and infections among women. This slide actually, infections among women have dropped, and we see that nationally. But if any of you happen to see Dr. Gallo's op-ed in the Baltimore Sun this past Sunday, 2 Sundays ago, he talked about some hot spots in the country where we actually are learning that those rates among some Black women have not dropped as much as we thought they might. I know that you saw the care continuum with Dr. Fauci. This bar says 82% of folks who are diagnosed, and now I think it's about 84. Something that I'm really, I come into the office very interested and concerned and hopeful about is that we can find these other 16%. I think if we really put our energy and thoughts into it, we can find what is about 180 to 200,000 people, and we need to put the effort and energy into doing that. I also am particularly interested in how we bring people who have been linked to care back into care, and I think that's a place where we also have to put a lot of energy as well. In every place along the continuum is important. I think those two will help us achieve better outcomes along the entire continuum. We still have to do better as well as we're doing. When we look at male versus female, male and female in our country, we see that there are some better outcomes for women. I wonder if that's just a matter of men, some part of that may just be that men don't go to the doctor. I mean, women have responsibility for their families, for themselves, and tend to do that, but there could be other factors as well. We continue to see persistent racial and ethnic disparities along the continuum, and we, as I said, important as well. In July of 2013, the Office of National AIDS Policy, the President launched the HIV Care Continuum Initiative, and it was created by a presidential executive order and responded to the advances in science and since the strategy's release. And the initiative is well underway. It's focusing on the continuum, looking at prioritizing expansion of testing and service delivery, encouraging innovative models, and ensuring that federal resources are appropriately focused on interventions that improve outcomes along the care continuum. The charge to the working group was for them to determine if there was appropriate emphasis among federal agencies on addressing the care continuum, to review research, to obtain input from grantees across the country, so to really try to get a better understanding from affected communities as well, to identify opportunities to improve outcome along the continuum, and to better align our efforts across the agencies. This piece, I know Dr. Fauci covered as well. We have seen just amazing scientific advances in not a very long period of time. So this slide actually was developed by Michael Mugavera, who has done some really wonderful work on retention and care, and just shows a model for really keeping people in care, the efforts that we need to expand and apply to bringing people into care. Many of you, I'm sure, have seen the actual document that was launched in December of 2013 that outlines our efforts and some recommendations for how to move forward on the continuum of care. It includes, from the National HIV Strategy, a set of indicators, 9 indicators. There was an update on those that showed some improvement across the way. One of the things, and I'll acknowledge Dr. Andrew Forsythe, who is also in the room, who has done some amazing work on these targets and indicators, and continues to do so since I've been in the office for all of 6 weeks. We have met, and we're talking about ways to strengthen this model as well. The recommendations from the working group included supporting, implementing, and assessing innovative models. Each of the speakers who has been up here has acknowledged a previous speaker. I would like to say that Paul Farmer is one of my heroes, and some of the work that his organization has done around the world, we all know. But what you might not know is, and he did not say, is he actually created that model in Boston as well. PACT is the name of the organization that he helped start. And one of the last things I did before moving into government was work with Dr. Farmer's colleagues in integrating a set of programs that we had at JRI with the PACT program. But it puts community health workers in communities to do the exact same thing he was discussing earlier as an international model. I think it's something we need to consider. I think it's something we really need to take a look at how we maybe can do that in places like Baltimore City, DC, in the southern US, in places in hot spots across the country. So it also discussed we need to tackle misconceptions around and stigma. We all know that. Something that recently was published, the CDC and the Department of Justice released an article addressing HIV criminalization. I think it's a great start to looking at and exploring how we begin to mitigate stigma in this country. It's not the whole answer, but it's a start. Strengthening data collection and coordination of data. I think we have to do that with partnering both with our federal partners, but also external partners. There's some people who are doing some tremendous work around data collection, and some of you, I'm sure, are familiar with HU. It's really helpful. It's accessible to lay people who are then able to take it and use it in their communities. Dr. Fauci talked about the $100 million award for CURE that responds to prioritizing and promoting research. And I think on day 2 of my job, I was on a call with a federal working group who is doing some tremendous work responding to recommendation 5, in that they are assessing and doing an inventory of all the training, curricula, capacity building, technical assistance that we have both inside government, but also that grantees have developed and pulling that together. So that work is moving right along. We know what works. We know some things that work, and I think the best combination of HIV prevention approaches will have population-level impact for specific populations. We have our new Affordable Care Act, which I think is significant for people living with HIV in many ways. As you know, it bans denial of coverage for pre-existing conditions, including HIV. Expands Medicaid eligibility to 138% of federal poverty level, created the health insurance marketplaces, established essential health benefits, covers preventative services, and lowers prescription drug costs for Medicare recipients, and increases resources to community health centers. At the same time, we know that there are states who have not yet expanded Medicaid. I'm going to believe they will, and it's a matter of time. But until that happens, it's another place where we have to be innovative and thoughtful in how we ensure folks who are living in those states are getting the care that they need, as well as the prevention services. The future of Limelight is, as you can imagine, it was one of the first conversations I wanted to have upon entering the White House, and I feel very confident in saying to you that the administration fully recognizes and supports the Limelight program, understands its role, and that it has to continue to evolve as we implement the Affordable Care Act, and there needs to be focus on improving care continuum outcomes. We have some challenges. I think also in Dr. Gallo's piece, he talked about the need for us to really have targeted testing and treatment. I think we have some room for growth there, room for growth in helping people access care, and then those social services and components that help people be able to maximize their health and well-being, and people have already talked about transportation, child care, and culturally competent care as well. HIV tracks right along with social and economic disparities. This slide shows prevalence in relation to high school education, employment, poverty level, and homelessness. It speaks for itself. I think it's also important to think about this particular slide looks at the impact of trauma with women. I think it also, we need to have a deeper exploration of its impact on gay men and all people who are impacted. This slide I love just shows a role for everyone. It shows a role for programs, for patients, for the service delivery, for healthcare teams, support services. If we're all doing our parts, we can move the dial on this. Another slide from Melanie Thompson, Michael Rivera, and some other folks that suggest some important ways for helping people stay in care, be adherent to their drugs, and maximizing healthcare, maximizing their health. I wanted to make sure to show to you that another one of my first meetings was with Lynn Rosenthal, who is at the White House and co-chairs with me the interagency working group on the intersection of violence against women and girls, HIV and gender-related health disparities. Next week we have a group of women researchers who are coming in to advise us and help us think about how to move forward. We've called a meeting of the working group on this, the federal working group, and it is something I wanted to state publicly. This is very important to me, and it is something that I will ensure our office maintains a very laser-like focus on. So as we think about implementation needs, there's a need for the continued collaboration across the federal government. I will tell you, I've been highly impressed and uplifted and inspired by the level of cooperation and coordination that's happening across the federal government. People are excited about what they're doing. I think, we all like to have a leader. And I think the strategy and the care continuum are evidence of leadership, and people have a direction, they have guidance, and I'm impressed with their commitment to moving forward. I think also having flexibility while maintaining alignment with the strategy's principles. I think a lot of what we're doing can be adapted and tailored, and I use that term explicitly in the research world. It doesn't mean just taking something and tweaking it in the way that one wants to tweak it. Really evaluating how changes make a difference in outcomes. I just won't go down this entire list. Something that I think is also important and a focus for our office is a more rapid analysis of surveillance data and use of data for public health purposes. I laud our CDC for their tremendous work and efforts, and as I said earlier, I think developing partnerships with others will help us move along with the data piece. The other DD talked about her model, and I think they're very similar, and we didn't talk about them. Working smarter through new models, more strategic, cost-effective approaches, and a shared responsibility, I think will lead us to the vision of the National HIV Strategy, where new infections are rare, and when they do occur, every person, regardless of age, gender, race, ethnicity, social, economic status, circumstance, or gender identity and sexual orientation, will have unfettered access to high-quality, life-extending care free from stigma and discrimination.